right now. Any questions? Nothing? Good. All right, I took it this morning. Fair, I think it's fair test. Let's just go through it. I've got my cheat sheet up here and, you guys can, go to work. I think you guys will do well on this one. Following Monday, a week from today, we'll be starting our final exam material. I can't believe how fast it's going. Final exam material, on the blood, and, following the Wednesday, next Wednesday, 10 days, 9 days, I guess. We'll be doing a, major thorough blood lab like they do at Peace Health, when they take blood from you and evaluate it for a certain type of illness, just to see where we're headed. What did we get on this one? Diagnosis, or let's do the heart rate first. First thing to do always is estimate the heart rate. What you guys get on this one?
40?
I got 40, 40-ish, all right? 45 if you did a halfie on the first one, but we're really looking at 4 pretty nice R waves in there. 1, 2, 3, 4 R waves here is what I counted, times that by 10, because you got 6 seconds down below. We got a heart rate of about 40. Bradycardia, tachycardia, or normal? Bradycardia, all right. Sinus or arrhythmic? Sinus. So I got sinus, bradycardia here. Heart rate of about 40. What else we got? Going down our list. What's that? Bundle branch block. I got bundle branch block as well. So bundle branch, you look up at the ABL picture, we got a bundle branch. Where else we see one? Here. Maybe up here on picture 2. Let me see if I can move that. You can look at all the pictures, I put them all up there. Yep, I say possible bundle branch block. I probably wouldn't mark it wrong if you said nothing on that, because I can only see it in maybe two pictures. You guys see any others?
Those first two on the third row.
Here, same picture there, that one and that one. So possible passable bundle branch block. What else we got? Maybe no delay. Very good. Because if you counted from here to here, that is 5 squares, 6 squares, 7 squares, 8 squares. 8 squares. 8 times 0.04 is 0.32. And that is above our maximum, which is 0.24. So it's definitely AV no delay. Bundle branch block, I wouldn't mark wrong or right if you said possible bundle branch block, because I only see a couple of them. So that's not something I would mark wrong. Good. What else are we supposed to know on these things? AFib, VFib? I don't see any. No. So those are your answers for that one. Good. Now, here's what I did on your exam. So there's no surprises. If I gave you some numbers, could you do some calculations and please show your units? What's SV? Stroke volume. The amount of blood ejected from the left ventricle in one cardiac cycle, which is a heartbeat. A lot of terms on this. I was reading that, I was like, yeah, it's pretty thorough. You have to do stroke volume. I put up stroke volume here 70. Is that a normal stroke volume? There's one question on the test. I'll just give it to you. I don't know what I was thinking. What is normal stroke volume for a patient? Anybody know? What's normal for, is there such a thing? I don't like normals. That's why I don't use them in class, but I asked that question, I'm like, that's a dumb one. And then I gave you like 20, 50, 70, or 100. And it really depends on if you're world-class athlete in here, but some of you may be. 100's not abnormal for a stroke volume, so there's no normal. So the normal on the answer on the test is 70 mils, all right? Which is, I guess if we averaged everybody in here, which is never a good thing to do, it would be 70. So that's a pretty normal stroke volume. So how do you get cardiac output is the question I'm asking for. What is the CO of this patient, which you find in a chart? Cardiac output is a calculation that you times stroke volume times heart rate is cardiac output. So we have to calculate some of these. So if we said 40 and the stroke volume is 70, the cardiac output is 2,800 mils per minute. 2,800 mils per minute is cardiac output. Cardiac output is stroke volume times heart rate. And this patient also is hooked up to a monitor, and we find the blood pressure is 140 over 110. What's the term for that? Is that high, low, or normal? That's high. That's hypertension. If you don't know those terms. A lot of terms on this test that I've talked about, but I want to make sure you know what they are. Hypertension is one, and that would be considered a hypertensive patient. What's the pulse pressure? Pulse pressure is systolic minus diastolic, so the difference between the two. Is 30. And I asked for mean arterial pressure, so given over a cardiac cycle, what's the average pressure in this person's heart? And I like to use diastolic plus 1/3 pulse pressure as my calculator. I gave you two equations you could use in your notes. So if you've got 110 plus 1/3 of 30, that's 10. The average is 120 millimeters of mercury. Do not forget to put units on this test, please. All right, let's do another. Now that I've kind of led you down the path. Here's your EKG. There's the patient data. Calculate, give me a diagnosis. Calculate cardiac output and mean arterial pressure for this patient. All right, heart rate, you guys still working? Need more time? What's heart rate? What do you do with that? Half. 1.5, 2.5, 3.5, 4.5, 5.5. Maybe 0.2 more. About 57 beats per minute would be perfect. 57 BPM. What's the problems with this one? Go through your list. Is that bradycardia, tachycardia? Bradycardia. Sinus or arrhythmic? Sinus. All right, so we got sinus, bradycardia. We got bundle branch block? Yep, clearly. Bundle branch block, see it in a bunch of pictures, 1, 2, 3. There's another one there at V3, there's another one here at V4. That's definitely bundle branch block. You gotta have it. You gotta have it on this one. The other one on probably yes or no on it yet. Bundle branch block. AV no delay. Nope. Close. If you said possible, if you actually measured them, here's where the P starts, here's where the R starts. That is 6 squares. That is right on the dot. I won't mark it right or wrong if you put AV no delay. And AFib, VFib? No. We got a patient with sinus bradycardia and a bundle branch block. Possible AV no delay or not. Come over here, stroke volume. What do we get, 57? Beats per minute times 50. Boy, it's a little early on Monday for me to do that one. That would looks like about 2850. Is that what you guys got? 2850 mils per minute. Did you bring your phone? Did we have this conversation? Yeah, bring your phone. All right. No Google searches. I gotta trust you. You guys trust me, I trust you. So I don't. 2850 mils per minute. If you didn't put the units, mark it wrong. Blood pressure, 160 over 100, systolic and diastolic. You're not tracking this yet. Systolic, diastolic, and you gotta calculate mean arterial pressure. Mean arterial pressure is diastolic plus 1/3 pulse pressure. So diastolic is 100, pulse pressure is the difference between the two, which is 60, and 1/3 of 60 is 20. Oh, same number, 120 over, that was a fluke. They don't always put mean arterial pressure as 120 because I did it twice this morning. That is just a fluke, I'm making stuff up. All right. You guys get that? You guys know what you're doing right now? Sort of, but it's good. You guys are reading EKGs and calculating patient data, and this is what you actually do. So this is good stuff. A week ago, you didn't know how to do this, and now you're actually making evaluations, and once we have these numbers, well, this patient, is that a good cardiac output for a patient? No, that's really low. That's a slow heart rate and a slow stroke volume. This is struggling. This patient's struggling. We like to see cardiac outputs around 5,000. So this is pretty low. Pretty low. Let's do one more, shall we? Third patient. Diagnosis, and then 2 calculations on the board, please. 82-ish, 85-ish? Good, good. I got a half here, ish. Actually, I'd probably go with about a 2 or a 3, but that's fine. 0.2 or 0.3. 1, 2, 3, 4, 5, 6, 7, 8. 2, about 82, 85. Perfect. BPM. Sinus, wait, is bradycardia, tachycardia, or normal? That's normal range, all right. Sinus or rhythmic? Sinus, looks good. So we got normal sinus rhythm. First definition. Little branch block? Nope. Maybe no delay? Nope. AFib? Nope. VFib? Nope. What do we got? What's wrong with this page? This is you guys. Nothing. Normal sinus rhythm. This is important. To diagnose normal as abnormal. Here's their stroke volume. 80 mils every time the heart beats. Pumps 80 mils out. Times 85. 6,800 mils per minute. This cardiac output. Pulse pressure, if their blood pressure is 110/80. Is that a good blood pressure? Yeah, that's good blood pressure. 110/80. So pulse pressure. Read my question. Not being arterial here, it's pulse pressure. What is pulse pressure of this patient?
30.
Systolic minus diastolic? 30 millimeters of mercury. Nothing makes you guys more angry when I mark something wrong because you didn't put values. Good. Can you define these waves? When you look at an EKG, so that's it. There'll be a couple of these, last 6 questions on the test is this, but man, is there a bunch of stuff on this. So even though you'll do calculations on the last 2 EKGs that are on the exam, what's the P wave? What's the P wave represent? Atrial depolarization. Excellent. It's not contraction. It's atrial depolarization. What's the QRS wave represent? Ventricular depolarization. All right. What's the T wave? That's a nice T wave. Nice picture of a T wave. All right. T wave. Ventricular repolarization. Okay. Ventricular repolarization. At this site right here, just after the P wave, are the ventricles filling or emptying? They're filling, because the atria are contracting now. What follows atrial depolarization is atrial contraction. And when the atria contract, they're pumping blood into the ventricle, causing the ventricles to fill. Are the AV valves open or closed? Open, because we're pumping blood through them into the ventricle. Are the bicuspid valves open or closed? They're closed. They're preventing backflow at this point. So you see how it's all related, and you have to take it to that next understanding level, is that these little squigglies, yeah, you can do the diagnoses today, but you understand what they represent. And there are multiple choice questions that simply say, the QRS complex represents A, B, C, or D, and it's ventricular depolarization. That's what it's doing. And then you have to link it to functioning in the heart about, man, are these valves open or closed? Is the ventricle filling or emptying? Pressure rising, pressure falling, and that comes off a picture I'll show you soon on cardiac output. All right, nice to know. Let me dig out my cheat sheet. How many valves in the heart?
4.
4. Good. Make sure you know all 4 where they're located, in between which chambers. There are 4 chambers of the heart. Left side thicker or thinner than the right side? Thicker. Why?
So the pump systemically.
Has to pump blood all the way to your toes. Has to pump at a higher pressure than the right side. Right side's only pumping toward the lungs, all right? Somebody give me a definition of an artery, please.
Carrying blood away from the heart.
Arteries carry blood away from the heart, does not have anything to do with oxygen content level. Veins carry blood to the heart. You know pulmonary circulation, having to do with right ventricle, pulmonary arteries to the lungs, and pulmonary veins returning from the lungs to the left atrium. The membrane surrounding the heart is called blank. We're going through the anatomy. Pericardium, all right? There is a serous fluid in that sac called pericardial fluid that prevents blank. Friction and heat, very good, friction and heat, excellent. There's the visceral and parietal pericardium picture out of your textbook, and the pericardial cavity with serous fluid. This is your model. It also represents a nice opening into the heart and a look at blood circulation. So if I said I'm a red blood cell in the right ventricle, I will be exiting the heart through what valve and what structure will I end up in?
Pulmonary.
You leave the pulmonary valve heading toward the lungs. And so you'll have to mix and match and try to figure out where we're headed next. So that's called coronary circulation, if you will, leading to pulmonary circulation, where you end up in the lungs. Chordae tendineae, this is all anatomy, terms that you'll need to be familiar with. Chordae tendineae, papillary muscle, both on the exam, know where they're located and what their function is. There's the difference between the pulmonary circuit and the systemic circuit. I'm comfortable that you know that when I use that terminology, that you know pulmonary circuit is from the heart to the lungs and back. Systemic circuit is from the heart to the body and back. When I'm looking at these, I don't know how much in detail I need to go here, but certainly need to know the location and function of the vena cava, which is draining oxygen poor blood from the body and back to the right atrium. Other things on the exam having to do with cardiac muscle. Terms to write down that you're comfortable with that are on the exam. Gap junction. Desmosomes. Intercalated discs. Syncytium. Maybe. Syncytium. What's SYN mean? Syn. You guys know what that is as a prefix? Together. It's together. Synthesis, for instance. Means the heart beats together. When we fire at the SA node, it becomes a functional syncytium. That's the term used for cardiac cells that are working as one unit. We don't just stimulate one cell at a time. We stimulate the whole heart, and it contracts together as a syncytial muscle tissue. I didn't ask anything about actin, myosin, troponin, or any of those things back in the old days of muscle contraction. But it's nice to know the differences, especially Do, cardiac cells have a longer refractory period, or a shorter refractory period when compared to skeletal muscle? Longer, and that's to prevent what?
Fatigue.
Fatigue. Very good. The term for this, when I do this with skeletal muscle and it locks up, anybody know that term? I'm giving it to you for a reason. When I do that and I lock up. Tetanus. Very good. Caleb's got it. Tetanus. All right, we think of tetanus as this thing you give with a rusty nail, but actually tectonic contractions are when we lock up, all right, and we can't do anything until we get more energy there or physically break the actin myosin bond. So with cardiac tissue, why we have a longer refractor period is to prevent tetanus or tectonic contractions from occurring. Because if the heart locks up, we don't pump blood. And if you don't pump blood, you're not going to live very long. How are we doing so far? Good? All right. Next topic in your notes to write down. Things to know about electrical conductivity in the heart. What is the pacemaker? The SA node. Have you found it on the model yet? Good. Do we get that uploaded? Brittany, that video of the model I
Yes.
did? Okay, thank you. Good. Somebody. I did it Wednesday, so I didn't know if it was the secondary pacemaker of the heart is called the what? The AV node. And the intrinsic rate of the AV node is what? 40. So if the SA node becomes dysfunctional because of a infarction, the AV node will take over. First question on the test. Forgot to do that. The pain associated with a myocardial infarction is termed blank. The pain. Anybody know that? The pain associated with ischemia or a myocardial infarction. When somebody's having pain in their heart or a heart attack, it is called angina. You guys remember that?
Yeah.
All right, angina. A-N-G-I-N-A. Actually, the full term is angina pectoris, because it's the pectoral muscles that seems like they're hurting. Angina is the term for pain associated with myocardial dysfunction. Also know with the electrical conductivity, the AV bundle, the bundle branches, and the distributing cells of the heart, which would distribute out the signal to all the cells, are called Purkinje fibers. All of these are on the exam. If we had a myocardial event that occurred right here and damaged that tissue, where would you find it on the EKG?
Bundle branch block.
Left bundle branch block, where would you find that on the EKG? In the QRS complex. That's why you get the split peak, because it's coming down here, and then it goes, ooh, I can't go that way, so it has to go around, and because when you go around, it takes a little more time, you get a split peak. So that's how you have to associate the entire heart function with what you're doing with the EKGs. if the myocardial event occurred here and caused the SA node not to fire, what would be the first thing you see on an EKG? You'd see AV node delay where that doesn't fire, so the first wave you would see is the Q, not the P. You understand that?
So you mean you wouldn't see the P?
Wouldn't see the P. If the SA node is damaged and not firing, the P is initiated by the SA node, depolarizing. If it's not depolarizing normally, would this patient stay alive?
Yeah.
For a while, because the heart rate is now
40.
40. I'm leading you down a path for the exam here. Don't know if you know why, but you'll figure it out on Wednesday about 8:15. So you really have to associate each little section with the big picture for this exam. The test is only on the heart. You guys all aware of that so far? I mean, the tests we've had this year have been on bones of the body or muscles of the body and all over the body. We're really talking about the heart here. So you have to understand it well and how things that affect one area can affect the other. I like it. I like it. Okay. Vagus nerve. That speed the heart up or slow her down? Slows her down. About how many beats per minute? 25 beats per minute. So if you nick the vagus nerve, the heart rate would increase about 25 beats per minute. Sympathetic, slow her down or speed her up. When you activate the sympathetic drive, does that slow the heart rate down or speed it up? It speeds it up. Could I cause your heart rate to go up right now?
Yes.
I could, all right? I won't do it, but I could. And that means you are releasing norepinephrine because that's sympathetic. Jess?
Did you say it slows down? The vagus nerve slows it? Or
Correct.
speeds it up?
The vagus nerve slows down the heart rate, about 25 beats per minute. And sympathetic speeds it up. What's the vagus release? Anybody remember? You guys, I know, you're like, wait a minute, this is not fair. This was last term. Vagus releases acetylcholine, slows the heart rate down. Sympathetic releases norepinephrine, speeds the heart rate up. Didn't ask anything about where the preganglionic neurons are located in the spinal cord or anything like that. We've had that before on other tests. Don't worry about any of that. I'm looking at the end results here. End results. There's our waves. Make sure you can describe what the waves are. P, Q, R, S, and T, and what they represent, and they're all written here. Atrial depolarization, ventricular depolarization, ventricular repolarization. Where's the doggone atrial repolarization?
It's hidden. It's hidden.
Good, it's hidden in the QRS. It's hidden in the QRS. You guys recognize these? I'd look at these in your textbook. One of them jumps out at me as something we haven't seen but is on your list, and that would be D. Anybody know what D is? That's VTAC. Ventricular tachycardia, we can't make out anything there. A is normal, a little fast, but normal. Tell me about B. It's always helpful for you guys, I think, to label the waves. And when you try to label the waves on B,
Oh, there's
what's
no
missing?
P.
There's no P. So what's not happening?
Atrial depolarization.
we're not depolarizing the atria because the SA node is not firing. I told you just a second ago, the P wave has disappeared. So what's probably the heart rate of B?
Around 40.
It's around 40, and it's being paced by the AV node. AV node. So this is significant, AV node pacing. It's called AV node pacing. Have you heard of that? You gotta write that down if you have. AV node pacing is V. The AV node's taking over and pacing the heart. There's no SA node. And then C is label of waves. What's this wave? P, QRS, T, P, P. So we're not getting another QRS should be sitting right here, and we're not getting it, which means this is an AV node delay problem. All right, that's how you define these. These are all in your textbook. You might look at them because they might be on the text. Ooh. You guys want to learn about this? This is huge. The toughest questions on the test are the timeline of cardiac output, all right? And these are things down here. Cardiac cycle, what's another name for cardiac cycle? Another name for cardiac cycle? Heartbeat. Perfect. Heartbeat. This is everything that happens in one heartbeat. It's called a cardiac cycle, all right? And how long are cardiac cycles normally? I'm just giving you the test. I just took it, all right? How long is a normal cardiac cycle? If your heart rate's 60 beats per minute, a cardiac cycle is 1 second, because you get 60 beats in a minute, so that's 1 per minute. But most of us are running about 75 beats per minute, sitting here right now, and 100 if you stuck by Dutch Brothers this morning, all right, and had a coffee to relax you, all right. So usually cardiac cycles are about 0.8 seconds. That's the normal, 0.8 seconds. That means every 0.8 seconds, your heart's beating. And what happens in that beat? And that's where the tough questions come in. I asked you these earlier, and you guys were kind of looking at me with the Monday morning 8:15 haze going. I got no idea. But this is how you determine after the P wave, are the ventricles filling? Yes, they are, because this is ventricular volume. Is pressure starting to go up? Yep, pressure's going up. The only one I'm concerned about on this chart when you're studying is the green one, period. I don't care about these other ones down here. I want you to know the green one, because this is 120 over 80, 120 over 80. Heart sounds here. What do heart sounds represent? It's on the test. What do heart sounds represent?
The valves opening and closing.
Valves opening and closing, very good. Mainly closing is what they call it. That's when you hear the loved up, all right? And you should be able to go here, and if I ask you, at the T wave, are the ventricles filling or emptying? They're emptying. That's the end of ventricular contraction, and they are still emptying, and you can find that up here. How much do we empty in a cardiac cycle? Well, we started at 130. We ended with a end systolic volume at the end of systole in a contraction of 70. What's the stroke volume? All right, should have started with that this morning. Stroke volume. Stroke volume calculation is in diastolic volume. How much blood is in the ventricles at the end of rest? 130 mils. How much blood is in the ventricles at the end of contraction, which is in systolic volume, which is 70. So the stroke volume of this patient is 130 minus 70, or 60 mils. Stroke volume. That's how you get after that. This chart covers it all. We're still there at the end of, or during the T wave. The AV valves open or closed? AV valves open or closed? We're pumping blood out of the heart, so we better not pump it back into the atrium, because that makes for a bad pump. They are closed. But the semilinear valves, because we're pumping blood out of the heart, are open. That's where these things come in. You get opening and closing of these systems, or open and close. I'll give you something where it's really clear, it'll be in the middle. So there's stroke volume, there's blood pressure, 120 over 80 millimeters of mercury. Love-dub heart sounds by the opening, closing of the valves, PQRS. Everything we talked about in here is on this chart for cardiac cycle. And you ought to be able to relate it to separate events, because everything's related. This is important. This is so important that they, not only have I shown in class, it's in your lab manual and in your textbook. And I've mentioned it a few times. So this is the summation page. And I told you earlier when I put this up that half your test comes off this one page right here. Did I not tell you that? And that's because now you can see that, oh yeah, because it's got the PQRS&T on it. It's got the valve on it. It's got the blood pressure on it. It's got stroke volume on it. And it shows you down below what's going on with blood in the heart. So that's all important. There is what we call a concept map in science of this, but put down in a map for you that shows you how things might change things for cardiac output. Cardiac output, we calculated it this morning, is stroke volume and heart rate. But these are the things that affect cardiac output. Like we talked about parasympathetic. Does that slow heart rate down or speed it up? Slows it down. And they're sympathetic, and it's going to speed it up. And so these are how factors might contribute to an increase or decrease in cardiac output. This one's on the test. What's hemorrhage do? What's hemorrhage do to blood pressure? Drops it, all right? You need to know increase and decrease. So things that increase, let's do this. Put another topic area on blood pressure. Things to know about the blood pressure. Certainly that it's in millimeters of mercury is the volume. Need to know terms like systolic and diastolic. And factors that contribute to blood pressure. First factor, constriction of tunica media. Increase. Good. So we're really, that's a good way to do it. Are we increasing or decreasing? When you constrict the tunica media, that's the middle layer of blood vessels. Does that increase or decrease? Increases blood pressure. Increase viscosity. I gave you that term last week. Viscosity. The blood gets thicker by more red blood cells, for instance. Does that increase or decrease pressure? Increases pressure. Hemorrhage. Decrease. You lose blood, you decrease pressure. It's one of the first things people on scene on an accident check in a patient is their blood pressure, because they want to see if there's bleeding, either externally or internally. And if your blood pressure is very, very low, you may have an internal bleed, and that's going to be serious. That's why they always check blood pressure quickly. All right. Low venous return. Decrease. Decrease. Low venous return. Decrease blood pressure. Layer that controls blood pressure in our body. The layer. Tunica media. When we talk about layers, we're talking about the tunicus, or the tunics. Tunica media controls blood pressure. What vessel is responsible for controlling blood pressure? We have arteries, arterioles, capillaries, venules, and veins. Out of those five, Arterials, thank you. Arterioles control blood pressure. Function of the capillaries. Exchange. Exchange. Then you also have to be able to relate this equation. Flow equals pressure over resistance. We're still in the blood pressure topic in your review notes that you're taking. Flow is what? Velocity. Flow is velocity. Where's blood moving the fastest? Arteries. Squirting out of the heart. Big pressure. Blood's moving fast. Where is blood moving the slowest? Capillaries. Going through the drive-through. Capillaries slowest flow. And can you then name, as we're going through this flow, fast, slower, super slow, a little bit faster, and somewhat fast, moving back toward the heart, there are three factors that contribute to venous return. Venous return. Three factors. Can you name one for me today?
Muscle movement,
Good, skeletal muscle contraction. Two,
breathing,
breathing, which are thoracic cavity changes. Anybody got the third one?
valves.
Valves, excellent. Venous valves, good. Somebody ought to study with Kayla. She's ready. I'm getting the feeling these guys are kind of waiting on studying for this test by your responses today, which is fine. You got 48 hours. But if this is all, seems like a French class for you today, this test will eat you up if you don't know terms, if you don't know those terms and don't have time to study. So I'm encouraging you kindly that don't let this one hurt your grade. You can do very well on it because I'm actually talking about everything that's on it right now. But if you don't study for it, it will eat you up. There's too much material. In comparison of arteries and veins, which has the largest movement? Veins. Veins are known as, write this down. Veins are known as capacitance vessels. I don't know how to spell it. Capacitance. There we go. Capacitance vessel. Capacity. That's what that means. That most of our blood, I know you guys don't know this, or maybe you do, maybe you read about it, I don't know, but you might be thinking that about half our blood's in our arteries and the other half's in our veins. That's not true. About 65% of blood in any given time in our body is in our veins. The capacity of our blood is mainly in veins and venous return. And the other 35% are in arteries, arterioles, and the capillaries. So a lot more blood in veins. There's pressure. Major pressure drop in the arterioles. That's how they regulate blood pressure. You'll notice the pressure in veins is incredibly low. So we don't use pressure to get blood back to the heart. We use skeletal muscle, thoracic changes, and valves. How about this? Yeah. Two matching sections, all right? Two matching sections, and if I said something like, that's a pretty straightforward. The arteries that feed the heart are termed what? Those are the coronary vessels, all right? an artery that might be found in the lower leg. And if I gave you tibial, subclavian, carotid, renal, you could probably figure out that tibial was the right one. So it's having an understanding of, I'm not looking for direction. I'm not asking you after a blood cell leaves the common iliac artery, where does it go next? All right, I'm not asking you to trace blood through the systemic system, but I do want you to know basically where the major arteries are located: head and neck, arm, torso, or leg. That's what I'm after. We good? If you can match those up, you'll be fine. I think they're pretty straightforward. Same thing for the veins. Basic head and neck, arm, torso, leg. And my favorite vein, did I tell you that one? Saphenous. Good. Somebody was listening. Saphenous, which probably means I put it on the test because I like it. All right. Most common clinical pulse point. Radial, right there, right there. Check my cheat sheet. Talked about pulmonary circulation. If I said pulmonary vein, what would you tell me about it?
It would be bringing blood to the heart from the lungs.
O2 rich blood from the
Lungs to the
lungs to the heart. Thank you, lungs to the heart. Make sure you know pulmonary. I also have a question on fetal circulation. So make sure you know ductus arteriosus, foraminovalis, and fossa ovalis. Terms. I just wrote these down to make sure you knew. Ischemia. 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 What is that?
damaged tissue.
Damage cardiac cells. Ischemic. They can go dead from there. That's called necrotic. Or they can be reperfused and go back to normal. Another term, infarction. Another term, pericarditis. Pericarditis. Perfect. Break it down. I started this today with you. I said syncytium. Use your prefix, you understand. I know you guys have medical terminology. You can break these down. Pericarditis is, itis is inflammation. Pericardium is inflammation, usually caused by an infection. Makes it tough to beat. And angina, if you didn't write that down earlier, which is pain associated. Another term, stenosis. Stenosis. S-T-E-N-O-S-I-S. Hardening. That's what stenosis is, and we can get stenosis of the valves, where they have to replace the valves. What's the most common valve replaced out of the heart? The mitral or bicuspid valve, because it's high pressure, left side. Good. Covered them all. Questions? Good. Questions? 8 o'clock, don't be late. That's all I got for you today. I'm here if you need me. Good luck.